So hello and welcome to CoProduce Care. Today we have Catherine Needham with us, and she's Professor of Public Policy and Public Management at Birmingham University. Delighted to have you on the CoProduce Care chat today. Thank you so much for coming on, Catherine.
Thank you.
So it's really useful if at the beginning of our chats you could just go through who you are, what you do, and what your interest is.
Sure. So yeah, I'm Catherine Needham. I work at the Health Services Management Centre at Birmingham University, and a lot of my research is on different aspects of social care. So I'm particularly interested in social care markets, in personalisation and personal budgets, and looking at kind of different sort of models of care and care innovation. Yeah, a few different things on the go around those sorts of things.
Great. Okay. So you've settled on one of the things that you're very interested in talking about is co-production, and specifically co-production research. What made you feel that you want to be getting into that area? Was there a need to co-produce, or did you just happen to be interested in that particular type of research?
I guess partly it was when I joined the Health Services Management Centre, it was already a kind of centre where there was lots of exciting work going on around co-producing research. And at that point, it wasn't something that I'd done before. And I was just really inspired by seeing some of my colleagues here and what they were doing. And I think there's, I suppose by kind of looking at what other people were doing, it gave me a sense of kind of how it would be possible. It was also kind of, I guess, made me much more aware of the kind of social justice elements of co-producing research, that when you're doing research about particular kind of communities that have often been quite marginalised, and where there are some real issues around sort of power dynamics with the state and with professionals and with academics, then there's a real compelling reason to think about how research could be done in that kind of much more partnership way. I think lots of universities are and other kind of research bodies are waking up to that and doing more of it. It's also, I think, being driven increasingly in part by research funders who are saying, we need to have a clear evidence in your bid of how you're going to involve people with lived experience in the research that you're doing. So I think because of some of the early work that people were doing to kind of really make the case for this, it's now become much more mainstream, and as I say, you have to, in a funding bid, make clear kind of how you're doing it, which I think is great. I think lots of it still probably isn't done awfully well, because it's something which isn't comes with certain kind of problems. It requires thinking and working in a different kind of way, and I'm not sure as academic researchers we've completely woken up really to what that entails. But it does mean, I think now there's a number of different drivers which are kind of mean that more of it's happening, and we should be able to kind of develop more of a kind of critical awareness of what works and what some of the barriers are.
So it might be quite a good thing to start off with discussing what co-production in research actually is.
Yeah, I mean, I'm sure there's lots of definitions available. For me, it's involving people with lived experience in the topic that you're researching in all the sort of different elements of the research project. So first of all, I think coming up with what are the kind of problems and questions that we ought to be looking at in social care. So, what are the kind of priorities? And so it's partly about agenda setting. I think that's one of the bits which can be the hardest, really, is to be involving people at the point where really things are getting kind of determined. Then it's also about once you've kind of got your idea, then involving people in the research design, involving people in the research itself, so the fieldwork, for example, and then once you've kind of generated some data, involving people in the analysis, in the writing, and then in the kind of sharing, dissemination, implementation of the research. So ideally, you'd want it to be running through all those different stages of the research process.
So really, it starts off from. Does it start from the point of what you actually research, to the research question, or is that one part where it's difficult to involve people?
I think ideally it should, but often it doesn't. And I think that's, to some extent, I guess reflects the sort of, as I said, the kind of power dynamics and also the realities of doing the research, that often it'll be the academic who's sort of the first mover who's got the kind of research question that they want to research, who understands that a particular research call has come up and, you know, maybe it would be nice to bid for that. So often some of the kind of big kind of topic areas are being, you know, already being identified. Having said that, even with a kind of topic area and maybe a particular kind of funding call in mind, I think it's still very much good practice to be involving people at that early stage in thinking through how you might actually address a particular question.
Yeah.
I think there's some practical difficulties with that. So one of the things we've been kind of pushing for at the university level is making sure we've got funding available, because at that point you haven't got your bid, you haven't got your grant, so it can't be funded from that. So it's kind of making sure there's money available within research organisations to get involved in that early stage design when the actual grant hasn't yet been won, that will otherwise would pay for that co-production of research.
And do you find in the way that you are involving people in each stage that changes the quality of the research? Do you feel that it's better informed and better taken up because it's so, you know, it's so participatory, if you like, or does it not really make any difference, or is it too early to tell?
I mean, I suppose there's a number of reasons why research doesn't get taken up, but I certainly think there's all sorts of advantages to. I think it helps you develop research which has more kind of validity, because I think the kind of the insights that people with lived experience bring to the research makes it more likely that you're asking people the right questions, that you're getting good data on the ground. So one of the things we've done is involved people who've got experience of using care services or of being carers, involve them in the interviewing process, and we think that generates just really good data because of the kind of the ability to build rapport and to gain that kind of shared sense of kind of sharing experiences, really, that you can get through that kind of method. So I think you get better data. I think it encourages you, when you're thinking about kind of what to do with the data, to write it up in a way which is actually easily accessible and understandable. So, you know, I guess we'd ideally like to be in a world where, rather than writing a plain English summary of the research, that's a much more natural way of communicating, and that all of our research is kind of written in that much more accessible way. And I think ideally, if you've kind of done a good job around the co-production of research, it does help with the implementation and the fact that it connects with what some of the issues are within localities. And I think particularly, although we've been talking about co-production of research with people with lived experience of care, obviously you can also co-produce research with people working in care services. So, you know, working with local authorities, perhaps on a kind of co-production basis. And then I think if you've got their kind of buy-in, that can help with implementation. Having said that, there is clearly lots of issues in the care sector which get in the way of research implementation. So I think even if you've got a kind of easily communicated, you know, very kind of powerful piece of research that everybody agrees with, that doesn't necessarily clearly then mean it will be translated into action.
Yeah, absolutely. You wrote an article with others recently. Yes. Participatory research meets validated outcome measures, tensions in the co-production of social care evaluation. So there's two bits that I was interested in that title. Firstly, what is the validated outcome measures? And then secondly, what are the tensions that come up in doing that type of research? I presume that it's talking about the tensions within doing research co-productively.
Yeah, so this was drew on a particular piece of research which we did, and particularly looking at how we might look at the outcomes of people using care services, and do a comparative piece of work. This was funded by the Economic and Social Research Council, and we wanted to compare the outcomes of care interventions based on the size of organisations. So whether care provided by very small organisations seem to get better outcomes than medium-sized and bigger organisations. And we did the research in we did involve people, although not until we won the grant, but at that stage we did involve people in working out how and where we were going to do the research, and then as co-researchers. And I think what we really found from that was there was a real pressure we felt from within the kind of academic community to use validated outcome tools, so those which have been established to have a particular kind of gone through a validation process, which means that there should be an understanding that when you ask the questions, whatever setting it is, then you're always likely to get a sort of stable answer.
So can I just ask, so I make sure I understand. So the validated outcome measures, it's just a standard set of measures within research. They're not co-produced necessarily.
No. So I mean, there may have been some co-production, way back in their design, but these would be things like the ASCOT survey, so the Adult Social Care Outcomes Toolkit, which is run by the University of Kent, which they very kindly make freely available on their website, and you can ask it, but you have to use it in the way that it's designed. So it's got, I think, nine domains, and you have to use their scoring format. And if you do that, you can produce data which can then be compared with other studies which have used the same toolkit. So the Department of Health does a biannual survey of users of adult social care services, and they also use that same tool. So the idea is then you get that kind of comparability, but you do have to ask the questions in exactly the way that they're on the survey sheet. So it's a standardized survey instrument, I guess we would call it. And so we wanted to use that so that we could develop data which we felt would the kind of academic community and the policy national policy community would consider to be valid data and reliable data, because it would use the standardized survey. But I guess what we encountered was when you then ask people with lived experience to go in and conduct the interview for you, was that they didn't like, the people we were working with didn't like this standardized tool. They found it really clunky, you have to put numbers next to things. They find that people kind of weren't necessarily interpreting the questions, the questions had to be kind of reworded to kind of make them clearer, which gets in the way of kind of this idea that they're always replicable. And actually what the co-researchers wanted to do was go in and have more of a kind of conversation with the people that we're interviewing. And in fact, that was the very reason why we'd recruited them in the first place, because of that idea that they'd have more rapport. So I think we just ended up feeling that there was a real tension, which in literature, which kind of purports to be about kind of, everybody agrees that co-production of research is a great idea. The National Institute for Health Research is very supportive of it, but organisations like NIHR are also very keen that we use these standardised tools. And I think we just wanted to kind of discuss the potential tensions, really, and kind of paradoxes in that, and that there's not always a very good fit. Co-produced research, I think, is much more about kind of emergent knowledge. You just let the interview kind of go with the flow. It's much more a kind of conversational interview. And when we tried to sort of stick a standardized survey in there, we just found it a really clunky fit. And so that's really what we get into in that article.
I think that's really interesting, because there's another article that somebody at Bristol University who was looking into the experiences of older people who were part of the LGBTQ plus community, their experiences in care homes. And I think they were using people with lived experience in carrying out the research. And one of the feedback that they gave was that they were given a questionnaire to ask those people who were in care homes, older people in care homes, and the questionnaires just didn't do the job. But what they did manage to do is to go back and review the questionnaires and co-create them. And then they came up with having discussions with the people that they were interviewing, with the staff that they were interviewing, and became more of a dialogue rather than a questionnaire. And because they were people with lived experience, they were able to impart their experiences of abuse because of their sexual orientation, and that was really helpful in helping the staff understand what they were going through, and they had some empathy from that. But it was through dialogue, it was through storytelling, it was through reaching out to people's emotions, not necessarily sort of asking very formalized questions, which I think is the point that you were trying to, the same situation that you had.
Yeah, absolutely.
Yeah.
And I think we just have that sort of tension we have to kind of live with, because neither of those, they both kind of have their benefits, but they're not easy to combine.
Yes, yeah. What I thought it was quite interesting is because I was also listening to a talk by somebody called Toby Lowe, I think his name,
Yeah,
and oh, you know him?
yeah.
Great. I'm hoping to get him on a chat as well. But he criticizes the idea of outcomes and
Mm.
outcome-based commissioning. And I can't remember exactly the term that he used. It was all about systems and being more human. And it links in really nicely with your idea of, that storytelling. And I wonder whether especially in research, we try, and increasingly through commissioning, people are looking for data and numbers, and that's traditionally in research that works really, really well. But when you're dealing with people, and especially social care, actually there's a bit of a disconnect between what the numbers show and could mean and actually how useful they are on the ground. For one example that I always think about is the number of safeguardings or safeguarding alerts. Initially, you would think if a service has a lot of safeguarding alerts, then they're probably a really bad service. But others might come at the point where actually they've got really good staff team who are psychologically secure in their job, and they are just able to report things more freely, whereas some organizations might have very low safeguarding but just might be hiding quite a lot. So that's an example where data might kind of conflict with the reality of and the experiences of people, whereas storytelling and the idea of a meta-narrative seems a little bit more useful in the idea of creating, knowledge in the area of social care. I don't know if you...
Mm. Yeah, I'm not sure. I guess to me that's sort of, they're two slightly separate things. So I guess one is kind of how, as academics, we make sense of things like the popularity of personalisation or co-production or some of these other kind of big concepts. Where have they come from? Why does everybody suddenly seem to be in favour of them? How do they kind of work? How do they garner support? And that's where I think the kind of meta-narrative is kind of useful, just to sort of understand the ways in which they build that kind of momentum around them through their very the sheer kind of malleability, that's an advantage, I suppose, rather than a disadvantage. Whereas my understanding of kind of the work of around the sort of problems of say payment by outcomes, outcomes-based commissioning, the work that Toby Lowe does, it's kind of a different thing. It's more of a kind of real-world dilemma, which is if you start to kind of pay people on the basis of outcomes, then they will start to game the system. And you will get distortions in the system, and that's really quite problematic. And so, we can see that in Wiltshire, who moved, one of the first councils to move to more of an outcomes-based commissioning approach to social care. What they found was that once they started paying providers on the basis of outcomes, then that started to change the behaviour of the provider organisations, and not necessarily in ways that had been anticipated. So you're very reliant on providers kind of reporting the outcomes accurately. If you're taking kind of an outcomes-based approach, which is about kind of recovery and getting people away from needing particular hours of care, then you've got to design incentives really carefully, because otherwise the providers are basically doing themselves out of a job. And that's the very difficult position for a provider to find themselves in. So I think what the kind of human learning systems that Toby Lowe and others write about is focused much more on, we all agree that that care and the provision of care should be about better outcomes for people, if we mean kind of more meaningful relationships and better lives and feeling more embedded in the community. But we shouldn't be kind of paying providers on the basis of securing those. We should be kind of helping providers to innovate, to experiment, and then to kind of bring the learning back. And we should be developing long-term trusting relationships with partners, rather than the very kind of transactional, contractual type of relationships that currently exist. And I think we're trying to sort of put outcomes on top of what is currently a very short-termist, low trust set of relationships, and that simply doesn't work.
In terms of the kind of organisations that do better in terms of being more co-productive or person-centred, do you feel that, you talked a little bit about the size of organisations, have you seen in any of your research that any size of organisation does better for people? I know with reported that smaller LD services tends to be more, this is, I mean, a couple of years ago, more likely to be rated outstanding than larger services. That might be outdated information now, but do you see the same sort of thing?
Yeah, so I think what we've been interested in a few different projects has been the kind of the role of scale in care. So the key thing that seems to matter to people in relation to home care is it the same person coming through my door? Do I know them? Do I trust them? Do they know me? And will they come when they say they're going to come? Those are some of the, they've just heard that again and again and again, as I'm sure any kind of care researcher has. And I guess what we found was the organisations that were kind of best able to deliver that were the small organisations. Now, the study that we did was a small scale study, so be kind of wary of kind of generalising from that. But it certainly does mesh with the CQC findings around the quality does seem to be better in smaller providers, and that has led them to put limits on the size of learning disability providers because of a feeling that there is a compelling case that they should be small. And I guess that kind of, to me, generates a question of, well, why would we do that for certain kinds of residential services, accommodation-based services anyway, and not for others? So not for those for older people, for example. And we know that the growth in the older people's market is in larger care homes. And there are clear economies of scale. We're in a very cash-strapped system. You can understand kind of how that dynamic works, but I think I have sort of concerns about how far the kind of lived experience is good in a kind of large travel lodge style care home.
Right.
Yeah.
Is there anything you've researched or heard or read that kind of doubt? Is there any research on that actually? The lived experiences of people in different sizes of care homes that you know of? Because I think that would be quite interesting.
So there's a project just finished, led by Stefanie Ettelt at the London School of Hygiene and Tropical Medicine on personalisation in care homes. Okay. And one of the things that, although I'm not sure if they specifically address the question of scale, they do talk about different models of care home and say, so some care homes are like hotels, those are the kind of more kind of high-end, often self-funded based care homes. Yeah. Some care homes maybe feel more like hospitals. Some feel more like home, and the fourth category, which they didn't find many of, but which she suggests, Stefanie and her team suggests maybe the kind of ideal, is what she calls a sort of flat share arrangement. So, people, I think often what people want, and if we're going to deliver kind of person-centered care, often what people want is something that feels like home. Yeah. But that might be difficult to deliver in a kind of residential setting, just because of the nature of kind of the high levels of need that people now have when they go into residential care. But sort of saying we don't know, that doesn't necessarily mean we have to sort of go down the hospital or hotel route. Maybe we could look at more, like I said, that sort of like a sort of student flat share, I guess, is the sort of model that I think she was talking about, and saying that, that, as I say, there aren't many examples of that, but that might be the kind of midpoint between something that feels very institutional and there's something that feels like a home.
Yeah, I think that's probably one of the things that we hear a lot, is that it's the smaller homes that are getting more person-centered care, but not, that's not like a rule of thumb, but you do hear a lot of people saying that in a smaller home it's more personalised. And also home care. Did you do any research around home care specifically, or does that have an effect on the quality of care, do you think? Because I suppose that's a next level up, maybe, where you are in somebody's home and so they're at home anyway, so it would make sense. But then obviously there's issues with loneliness and isolation, so it's a different type of challenge in home care.
Yeah, so most of the work that I've done has been in home care, and so our micro enterprise project was looking at those very small organisations compared to larger, and finding that the better outcomes were associated with the smaller services. I mean, as I say, I think the smaller organisations were better at being able to establish relationships and continuity of support amongst the same people, whereas the larger agencies relied on their kind of flexible staffing base, which meant they could move people around in, you know, a more agile way, and that makes sense for potentially the sustainability of your business and for you know, for getting staff where you need them to be. But it doesn't necessarily mean that people are able to kind of develop those relationships. So I think you know, generally I think some of the kind of quality issues have been more evident in those larger services. But obviously, you know, in a very difficult market, it may be that the larger services are more able to be more sustainable. I mean, I think there's a real mixed picture. You know, organisations are handing back contracts for home care, and I think they're from the small, medium, and large providers. So it's not evident that kind of one is surviving while the other isn't.
And you've talked before a little bit about workforce and the challenges for the social care workforce. Can you talk to us a little bit about your interest in that area?
Yeah, I mean, I haven't done a huge amount on workforce, but I think I guess anybody who's interested in social care will see the huge issues that we've got in terms of workforce shortages. So in the recent project we've just finished around shaping care markets, the key number one issue that providers told us was that was a problem for them was recruiting staff. You know, so we would go one of the care homes we went into there. You know, the care manager was talking about people repeatedly not turning up for interview, how hard it was to fill posts, and we know that can particularly be an issue for home care agencies, that if people are going into care work, it can be more appealing to get to work in a care home where you're in a kind of a room where you've got a space where you've got colleagues, you kind of, you know, got a more predictable workflow, you haven't got to travel with all the issues of not being paid for travel time. So I think you know, there's lots of issues that make home care in particular a very unappealing sector to work in. You know, we know that people can do similar work in the NHS for on a much better salary, and so all these things make it very hard to get workers in social care.
And in terms of some of the projects that you're involved in at the moment, could you talk to us a little bit about what the Health Services Management Centre is, and what it does, and kind of research that's going on there at the moment?
Yeah, so we do all sorts of, I guess, research around the health service. So we run the Leadership Academy programme for the National Health Service, along with partners, and lots of my colleagues do kind of evaluation work, particularly around health and social care integration. So working in local sites, look at how far integration is being developed in a successful way. A couple of projects that I'm particularly involved in. So there's the Shaping Care Markets one that we're just going to be reporting on in the new year, and that's been looking at the extent to which local authorities are fulfilling their market shaping duty under the Care Act 2014. So they were given this duty, quite an ill-defined duty. So we've been looking at kind of some of the issues that they've been facing as they try and implement that. And I guess the other one, main one I'm working on currently, is an ESRC project linked to the University of Sheffield around care in the 4 nations of the UK. So sort of 20 years on from devolution, what can we learn from the different paths in social care that we've seen taken by Scotland, Wales, Northern Ireland and England?
Both of those projects are just so interesting. I don't know how much you can talk about them, but in terms of the first one, Shaping Care Markets, I think that's a particularly interesting one, because being in a few commissioning meetings myself, you find it sometimes you don't get a lot of the guidance from local authorities about where they feel that markets should be going. Sometimes it's the opposite way, and they say, well, market forces, you let us know what you can provide and we'll go from there. Are you seeing that there's a shift and that local authorities are starting to give more guidance now?
I think it varies, and that's one where I probably can't say too much about, because that's out for peer review and will get signed off by the department. But I guess one of the things we found was how complex markets are even within a locality. Right. So if you go and sort of talk to a local authority about how are you shaping your care market, they'll say to you, well, which market? Do you mean, you know, for older people, for working age adults? You know, do you mean building-based services or in the community? Do you mean for self-funders or for people who are funded by the local authority? Those are all different markets. And you know, as they try and kind of shape those, which, you know, the market's generally not very amenable to being shaped, so it's quite a challenge already. And they're also trying to do that whilst also being influenced by local NHS commissioning practices. So some of the local authorities will say, well, we can't get places in care homes because they've been bought up by the NHS, and the NHS pays better. They will pay a higher fee than we will. So we can't get the beds. Or they'll say, we can't get staff because we neighbour a borough that pays a higher hourly rate for care than we do. So if people want a job in that sector, they'll just go to the next door borough. So you not only got the kind of complexity of the sort of local authority market landscape, it's all these different kind of layers on top of it. So what we've been trying to do in that project is sort of disentangle some of that.
Do you think it's too much of a big ask then that the Care Act has given local authorities to say that it has that duty?
I think it's, I suppose if we hadn't had such an austere financial context within which it could be implemented, then I think local authorities would have had a better shot at doing it. I think it's come at a very difficult time. So although spend on social care has started to go up again, the allocations of money have been quite short term. So, you know, here's a bit of money for this year, here's a bit of money for next year. Actually, to build up kind of long-term relationships with providers, which might involve investment in building-based services like extra care facilities, for example. You need a kind of sustained kind of long-term plan. You need good relationships.
Yeah.
You need a kind of co-commissioning, co-production with communities. And my sense is that local authorities are living much more hand-to-mouth than that. And that just means that the kind of short-term, can I get somebody out of this hospital bed and into a care home, takes precedence over kind of, can we plan this to actually do this well.
Yeah, and I think like what you said about the different priorities for different areas of the health and care sector, where you have the CCGs, you have the local authorities, then you have the providers, and then the whole population that we're trying to serve is so diverse. Without that coordination, and that's not supported through the regulations or the systems that we have at the moment, it's really difficult to make it all joined up. So it'd be fantastic to hear what comes out of that work that you're doing. And then the second piece on the 4 nations, I know from doing a little bit of research on how co-production is approached in different areas, it's been really interesting what, for example, Scotland is doing, and some of the initiatives that they have are really almost a little bit sort of forward progressive looking from the outside. I don't know if it's true from the inside if you're working there. Is there anywhere at the moment that you feel is ticking a lot of boxes from the perspective of people receiving services?
Yeah, I mean, I think we're learning some really interesting things by looking at the 4 in comparison. So somewhere like Scotland has free personal care. So you don't, if you're being looked after in your own home or in a residential setting, you don't pay for the sort of personal care element of that. And that's really interesting because that's one of the things that was in the Labour Party manifesto in the last election. So it's something that people are looking at doing for England. So we've got this great kind of natural experiment in a way where we can say, well, let's see what they're doing in Scotland because they've had this now for several years. And I think what's interesting about it is, firstly, that it increased demand. Once you start charging for people, more people want the service. So if you're already kind of struggling to meet your demand, that's something you're going to have to kind of take account of. The second was because of this is happening without any sort of new investment into financially, it's having to be rationed. So although it's no longer being rationed sort of financially, it's therefore only people who are at the very highest level of need are able to access it. So that means that money's maybe going into looking after them that could alternatively have been going into preventative services and early intervention. So you're kind of spending money at the kind of, you know, the sort of downstream, but you know, we all know, and the Care Act says that we should be thinking much more about prevention and upstream interventions. And then the third thing is that people find it really confusing because it will pay for your personal care, but it won't pay for your hotel costs in a care home. So it doesn't pay for your like sort of board and lodgings. So the kind of, I mean, clearly have that issue in England that people don't understand how care gets paid for, and it's very confusing. But actually, the sort of Scottish system hasn't got rid of that. It's brought in kind of almost a different type of confusion between what gets paid for by the state and what doesn't. So I think there's quite a lot of learning there for if England were to go down that route, what some of the implications might be. Another area where Scotland's led the way is on regulation of the care workforce. So care workforce now regulated in Scotland, and Wales is also moving in that direction. So that's coming into force. You'll have to be registered to be a care worker in Wales as well. And that's something which has been talked about in England. Lots of people are very supportive of it, but there is a sense in how far does it discourage people from going into the sector. I think in Scotland you can work for up to 5 years without going through the full registration process, so there is some suggestion that people might leave at the end of that period to avoid the costs, because there are some costs with registration. And it also formalises the care workforce, which lots of people think is a great idea. But if you think that personalisation, personal budgets are about sort of permitting a more informal workforce, more personal assistance, more ability to kind of employ maybe friends or family members, and to sort of say to the person using the service, it's about you, it's about your choice and control, then worker registration reduces that choice and control again. So that's another reason why it's been quite controversial.
I wonder why it is that places like Wales and Scotland are taking up the idea of registration so much sooner than we are in England.
Yeah, they're much smaller. They're like, they're kind of yeah. So I think the policy community is smaller. It can work much more quickly. So if the population of England is sort of 10 times the size.
Yeah.
So scale-wise, it's very, very different. I think in England we've been stuck in this limbo while we've been waiting for a green paper, which has meant that nothing else significant in relation to care has happened. And I suppose we've all been kind of holding our breath, waiting for this kind of new intervention. In the meantime, being obviously very concerned and time taken up with Brexit and all of its implications. And so I think kind of big issues like care worker regulation haven't been able to get the airspace.
In terms of, so we're the other side of the election, in terms of your wish list, do you have one or two things that you would like the newly appointed government to concentrate on in 2020 and beyond?
Yeah, I mean, I guess it's one wish, but it's such a big one that I feel like it would take up like space for like one or two, which is we need a kind of new settlement, a new kind of beverage. We need a new understanding of who will pay for care, how that will be funded across the life course, what the distribution will be kind of between the generations. We've clearly got a system which is not fit for purpose. The amount needed just to keep a kind of the billions that are needed just to keep the current system on the road, when the current system is really not great, suggests that these kind of influxes of cash that we've been having are not the way to go. We need a sort of back to first principles kind of approach. The chances of that happening seems so very low, unfortunately, because I think it does require cross-party consensus. And we know that any time recently the politicians tried to kind of say, let's think differently about how we fund social care, that they've been so effectively torn apart by the press and the other political parties that you can understand why people don't want to go there. So we don't want another kind of dementia tax or death tax, or these things are so easy to critique. So we need to be looking at other places like Japan, Germany, who have kind of grasped this nettle of long-term care funding, and think, well, if other places have done it, can we learn something from how they've done it and move in that direction?
Is it just a case of parties and politicians being a little bit more brave with this and not so worried about scaring off the electorate? In fact, we're talking about the issues around health and social care so much over the last 2 years, more than I've ever known it being on the news. It's incredible. Is the awareness not there now? Maybe it's time to just take bull by the horns and just do what might seem very unpopular, whether it's raising taxes or delivering a different kind of way. Do you think this is the time to kind of push for that change?
Yeah, definitely. And Boris Johnson's got a big majority. That if you can't be brave at that time, then when can you be brave? We've had sort of governments with slim majorities for the last few years when you're much more constrained in what you can do. So I certainly think now's the time. I think talking about some sort of hypothecated tax, for example, could be something which we could get into. But I think, and you can see this in the way that Boris Johnson and some of the people around him talk about this, they're really unsure about how they deal with things like people's sense of attachment to their home. So once you start talking about, well, people have to sell their homes for care, then you're immediately kind of pushing buttons, which I think become very difficult. So I think it's kind of having bravery around some of those conversations, and recognizing that we do have to talk about people's homes as potentially sources of funding for care, or thinking about more redistributive approaches, or moving more in the kind of NHS type direction in terms of how it's funded.
Just before we go on to Cactus questions, what's the hypothecated tax?
So that's where you pay a tax, but it's for a particular item, so it can't just be put into the general government budget. So yeah, it's exactly. So it's a ring fence thing. So I believe Gordon Brown did something similar, where I think he put a 1p on national insurance for the health service earlier this decade when he was in power. So I think it has been done before, but I think it's a way of sort of building trust, because people don't kind of think, oh, I'm going to pay that and then it's going to go on something I don't want.
Yeah.
You're able to sort of to ring fence it.
Yeah. That's helpful, thank you. So yes, in terms of Cactus questions, I don't really have that many for you. Just the one that, because it's Brexit is going to be done by the end of January, presumably. What do you think might be the challenges for your area of research that Brexit may or may not bring?
Well, I think there's clear workforce issues. I guess that's really the big in relation to Brexit. So we were already, I think, clear that people are discouraged from coming to work in the UK. If we put in a kind of skills or earnings threshold, then that might make it very difficult for people to come in and work in care, where the pay is low, and that's not traditionally been a kind of skilled sector in terms of qualifications. Although care is not the sort of proportion of the workforce from the EU is not particularly high compared to, say, hospitality industry. I think when you've got a sector which is very kind of precariously balanced in terms of the sustainability of lots of the providers, then certainly in some parts of the country, just making workforce shortages even more profound, I think, will be very problematic. So I think that's clearly where Brexit is likely to have its first effects.
Yeah, and in terms of the research, the projects that you're involved in at the moment, the ones that we talked about, shaping care markets and care in the 4 nations, when can we expect those to be published?
So the shaping care markets will be out in the spring. That's a bit vague, but I guess around Easter time, hopefully. We just need to get that signed off. So we'll be making that available soon. And the care in the 4 nations, we're partway through that, so that'll be more into, I think, 2021 before we've got our kind of final findings. Although we will be sharing the learning along the way during next year.
Brilliant. And just finally, for anyone who's trying to do research co-productively, do you have any tips for doing it well?
Gosh, lots of things I could say. I mean, I think you have to resource it. And that can be one of the really difficult things. So I would say go to the Involve website. There's a huge amount of really useful materials on there about kind of how you do it well, but also about how you need to pay people. You can't expect people to give their time for free. So I think making sure that people are kind of understand the commitments that they're making through taking that approach. And there's lots of good practice out there, guidance, and certainly Involve is often where we go if we're looking for kind of making sure that we're doing things the right way.